Welcome to the deep dive. Today we are strapping on the scrub hats and stepping into the orthopedic operating theater.
Metaphorically speaking, of course.
Right, metaphorically. We aren't just discussing surgery, though. We're really dissecting the basic biological science of, well, failure and recovery in the knee.
Mm-hmm.
We've pulled together a pretty comprehensive stack of source material, the core biology, the biomechanics data, and, the latest clinical attempts to kind of cheat Mother Nature. It all focuses on optimizing outcomes after these really devastating ligament and meniscal injuries.
It's an essential deep dive, definitely. Because, look, every successful outcome, it really hinges on recognizing the fundamental constraints of human biology.
Mm-hmm.
Our mission, whether we're repairing a meniscus or reconstructing an ACL, it's always about preservation.
Preservation, okay.
Yeah, the knee is just a remarkably complex mechanism. You've got the ligaments providing those static, passive restraints, right?
Mm.
And then the menisci, they act as the crucial load-distributing gaskets.
Gaskets, I like that.
If you disrupt either one, you immediately alter the joint's kinematics.
Yeah.
And the forces acting on the cartilage change. The sources are really definitive on this. This altered balance, it inevitably leads to premature degenerative changes. We are constantly in a race against that inevitable slide toward osteoarthritis.
So I'm approaching this as the junior resident here, needing absolute clarity on the fundamental biology that dictates our entire treatment approach. Why does one ligament heal beautifully while the one right next to it just dissolves?
Yeah.
And why is losing that tiny wedge of fiber cartilage such a catastrophe for the joint? We really need to look past the sutures and screws and understand what the tissue is actually doing at the molecular level. So let's unpack this. What exactly is a ligament, functionally speaking, when you get down to the microscopic level?
Okay, let's start with a microscopic blueprint then. If you take a biopsy of, say, any major knee ligament, what immediately jumps out is its incredible design for tensile strength. It's primarily water, yeah, but of its dry weight, somewhere between 70% to 90% is type I collagen.
Wow, that high.
Oh, yeah. This is the bedrock protein. It provides that super high tensile strength and the characteristic form that defines a ligament.
So type I collagen is like the high-strength steel cable of the system, but the structural arrangement is what really matters, isn't it? It's not just a glob of protein.
Precisely. It's an exquisitely structured cable system. The collagen molecules, they align axially, right, to form microfibrils. And here is where we get into the technical detail that truly distinguishes a healthy ligament: the fibril distribution. Ligaments, unlike, say, simple tendons, they exhibit a bimodal distribution of fibril diameters.
Bimodal, meaning two main sizes.
Exactly. You have a group of smaller, thinner fibrils, typically ranging from, let's say, 40 to 75 nanometers in diameter.
Mm-hmm.
And then you have a second larger group, maybe 100 to 150 nanometers.
That bimodal distribution, it must serve some kind of functional purpose. Why the two sizes of cables?
Well, think of it this way. The thinner cables are probably recruited first, maybe under lower, faster loads. While the thicker cables, they provide the ultimate robust structural integrity needed for maximum strength.
Ah, okay. Different jobs.
They work in tandem, basically, allowing the ligament to handle a really wide range of stresses. Now, these fibrils are grouped together to form fibers, which are then organized into the functional subunits we call fascicles. Some of those can be over a millimeter wide. This whole structural hierarchy gives the ligament its characteristic resilience.
And that resilience includes its rate-dependent behavior, its viscoelasticity, right? Collagen is strong, sure, but what gives the tissue its specific give and shock-absorbing quality?
Ah, that's where the biochemistry gets really fascinating. Collagen is woven into this extracellular matrix that also contains these negatively charged proteoglycans molecules like decorin, chondroitin sulfate, and keratin sulfate.
Proteoglycans, PGs.
Right, PGs. And these PGs are like little sponges. They aggressively attract and trap water within the matrix. This pressurized water, held by the PGs within the collagen lattice, that's the source of the ligament's viscoelastic property.
So the water acts almost like a built-in hydraulic damper?
It does, yeah.
Yeah.
It dictates that rate-dependent response. If you pull a normal rope quickly, it snaps, right? If you pull the ligament quickly, it actually stiffens, thanks to the resistance provided by that constrained water.
Yeah.
You can almost visualize the ligament like a smart braided rope made of steel cables, that's the collagen, and interwoven sponges filled with water.
Okay, that's a great analogy.
It gets exponentially stiffer the faster you try to pull it. This property is absolutely crucial for rapid energy dissipation and protecting the joint from sudden impacts.
And the maintenance crew for this entire complex matrix, that would be the fibroblasts.
Yes, the fibroblasts are the dominant cell type. They're responsible for the constant maintenance, degradation, synthesis,
Yeah.
keeping the matrix healthy. And interestingly, our sources suggest that ligaments are actually comparatively more metabolically active than tendons.
Really? More active.
Yeah. Ligament fibroblasts often have plumper nuclei and higher total DNA content compared to tenoblasts, the cells in tendons. They are hard workers, constantly sampling the mechanical environment and adapting the matrix accordingly. Hashtag B, ligament insertion sites and neurofunction.
Okay, that clarifies the main substance of the ligament, but the real mechanical challenge, I always think, is that transition point, where the soft tissue cable meets the rigid bone. We know the ACL and MCL handle load transmission differently, which must mean their anchoring points are also radically different.
Absolutely. That transition, the insertion site, it has to be robust enough to prevent failure under extreme load, but also flexible enough to manage the huge strain gradient going from soft tissue to hard tissue.
Yeah.
We generally classify these sites into two crucial types, as Galata and Rodeo discussed.
Okay, let's start with the more complex anchor, the direct insertion.
Right, the direct insertion. We see this, for example, at the femoral attachment of the ACL. It's a more sophisticated gradual system. Instead of just a hard stop, the tissue transitions through 4 distinct specialized zones.
4 zones.
Okay. First, you have the dense ligament tissue itself. Second, it shifts into unmineralized fibrocartilage. Third, mineralized fibrocartilage. And then finally, you hit the bone.
So it's like a built-in strain buffer zone, designed to stop shear failure right at the interface. What makes those intermediate zones so unique biologically?
Well, as you can see detailed in figure 36.1, those zones rely really heavily on cartilage-specific collagens, types 2, NiXX, and the other. Type X collagen in particular is considered absolutely fundamental. It acts almost like a gatekeeper, regulating the mineralization process and maintaining that functional boundary between the unmineralized and mineralized fibrocartilage. If that interface fails, the whole anchor system is compromised.
Okay, that makes sense. And the MCL, using the other approach, the indirect one.
The indirect insertion, which is common at the tibial attachment of the MCL, is more like an aggressive, fibrous weld. It's depicted beautifully in figure 36.2. Here, the collagen fibers of the ligament, they don't transition through fibrocartilage. Instead, they blend directly into the outer layer of the bone, the periosteum.
Directly into the periosteum. How do they anchor?
They anchor via these obliquely oriented Sharpie's fibers. These fibers are essentially like strong tacks driven into the cortical bone at an angle. It provides a huge surface area for load dissipation.
That clinical difference is massive. We often see in, skeletally immature patients that tension on the MCL will actually avulse a piece of bone because those Sharpie's fiber attachments are stronger than the underlying growth plate. The failure happens in the bone, not the ligament itself.
That's precisely right. The strength of that fibrous weld often shifts the failure point somewhere else. Now, let's just step back for a second from the static mechanics and talk about the ACL's most subtle, yet maybe most vital function, its somatosensory role.
Ah, the knee's internal GPS. Yeah, this function often gets lost when we focus purely on static stability.
Exactly. The intact ACL isn't just a passive rope, it's a sensor array. It contains specialized mechanoreceptors, mostly Ruffini endings, which sense stretch and position, but also Pacinian corpuscles for acceleration and vibration, Golgi tendon organs sensing tension near the insertion, and free nerve endings for pain.
Wow, quite a collection.
Yeah, and these neural elements, they might only be about 1% of the total tissue volume, but they're concentrated in that subsynovial layer.
And the relevance of these sensors, what do they actually do for the knee?
They detect minuscule changes in tension. They provide the central nervous system with critical, real-time feedback information about the direction, speed, and acceleration of joint motion. This somatosensory feedback is absolutely critical for dynamic stability. It tells the surrounding muscles, the quads, the hamstrings, exactly how and when to fire to prevent the joint from getting into a dangerous position.
So when a patient tears their ACL, they don't just lose a static restraint, they lose a really sophisticated early warning system, which must contribute significantly to that feeling of instability, even if we restore the mechanics surgically.
That's the essence of the functional deficit, exactly. We can restore static stability with a reconstruction, often quite well, but we really struggle to restore that perfect subconscious neural input. Pittman and his colleagues provided definitive evidence for this neuroreceptive function. They recorded somatosensory evoked potentials, SSEPs, from the scalp following intraoperative stimulation of the ACL.
So direct nerve communication to the brain.
Absolutely. The nerve is definitely communicating. And understanding this function is what drives the complexity of modern ACL rehab, focusing not just on muscle strength, but heavily on proprioceptive re-education, trying to retrain that sense of joint position. Hashtag tag biomechanical benchmarks for ligament health.
That complexity really underscores the need for objective measurement. When we assess a ligament's function, either pre-op, post-op, or, in the lab, what are those four non-negotiable pillars we use to define health? I think Frank outlined these.
Right, the four pillars, laxity, stiffness, strength, and viscoelasticity, are our fundamental metrics. You can see them laid out in figure 36.3. These allow us to distinguish between, say, structural success and the actual material quality of the tissue.
Okay, let's break down the first three. Laxity, stiffness, and strength. They seem related, but they measure distinct aspects of failure, right?
They do. Laxity is basically the displacement of the bones before the ligament even takes up any significant load. Structurally, it reflects how easily the fiber bundles are recruited. If a ligament is too lax, the joint moves too far before that static restraint kicks in. Think of it as just too much slack in the rope.
Got it. Too much play.
Then stiffness. That's the slope of the load displacement curve once the fibers are engaged. It's the load required to displace the bones once the rope is taut. A repaired ligament might have the right length, so low laxity, but if the individual fibers are weak or sparse, the stiffness will be low, meaning it stretches too easily under load.
Okay. And strength, the ultimate test.
Strength is the ultimate structural test, yes. It's the maximum tensile load the entire bone-ligament-bone complex can withstand before catastrophic failure. It depends on both the number of collagen fibers and their quality, how well they're cross-linked.
And the fourth pillar, viscoelasticity, is critical because it captures that dynamic, time-dependent nature of the tissue we talked about.
Correct. Viscoelasticity explains how tissues respond to changing mechanical environments over time. This property accounts for some significant fluctuations under just daily physiological loading. We can see changes up to maybe 10% in length and even up to 70% in load. We differentiate this behavior into two classic phenomena, which are nicely illustrated in figure 36.4.
Creep and load relaxation, how do you clearly distinguish those? I sometimes hear people mix them up.
Yeah, they can sound similar. Think of it practically. Creep is what happens when you apply a constant load. Say you're just standing still for a long time, and the ligament slowly, progressively increases its length over time. The tissue elongates under that steady pressure.
Like stretching memory foam.
Exactly like stretching memory foam. The length increases while the weight stays the same. Load or stress relaxation is the inverse. This happens when you hold the ligament at a constant deformation, maybe fixing the knee rigidly at a specific angle. Over time, the tension or load within the ligament decreases, even though its length hasn't changed. The ligament is relaxing its internal stress.
Okay, so constant load leads to creep, more length. Constant length leads to relaxation, less stress.
You got it. Both phenomena are dictated by the movement of water out of that collagen PG matrix under stress.
That makes the distinction much clearer. Now, to measure all this, we use two separate testing curves in the lab, which helps separate the overall architecture from the quality of the material itself.
Exactly. The load elongation curve, which you see in figure 36.5, gives us the structural properties of the entire system, bone, insertion site, ligament, mid-substance. It defines things like linear stiffness and the ultimate failure load. Crucially, it displays the toe region.
That initial low stiffness part of the curve, what is that toe region physically representing? Is the tissue actually stretching yet?
Not really stretching, no. It's purely the straightening out of the collagen fiber's natural, wavy, relaxed structure. We call it the crimp pattern. The ligament isn't actually elongating much, it's just unfolding its internal slack. As soon as that crimp is gone, bang, you hit the linear region and the full tensile strength of the fiber bundles is recruited.
Okay. And the second curve normalizes the measurement to the tissue itself.
Right. The stress-strain curve, shown in figure 36.6, normalizes the load to the cross-sectional area, that gives you stress, and the elongation to the original length, that gives you strain. This gives us the true material properties, like the modulus of elasticity and the tensile strength. A stiff ligament has a high modulus of elasticity.
Makes sense.
The clinical takeaway here, which really guides our surgical technique, is that the ligament is highly specialized. Applying force directly along the line of the ligament recruits the maximum number of fiber bundles simultaneously. That results in the highest measured forces. So as surgeons, we must try to reproduce that specific fiber orientation to maximize the strength of our reconstruction.
Okay, understanding the ideal structure really sets up the core biological contradiction we see in the knee. Why does the MCL, the extra-articular ligament, have, as you said, a relatively good but seldom perfect chance at healing,
Yeah.
while the ACL, sitting right next door inside the joint, almost universally fails to heal on its own?
It's the classic difference between trying to heal in a quiet, nurturing environment versus trying to heal in a hostile, biologically corrosive environment. Let's first look at the MCL success story, which relies on that classic three-phase healing cascade common to many soft tissues outside the joint capsule.
So phase 1, inflammation. What defines that critical initial stage?
Phase I, inflammation. This is immediate. The trauma causes bleeding, and you get the formation of a fibrin clot. That clot serves as the absolutely essential provisional scaffold.
The initial framework.
Exactly. Cells release powerful vasodilators like histamine and serotonin. This brings in macrophages and other inflammatory cells to clear debris. It's a massive cleanup operation. Crucially, near the end of this phase, capillary endothelial buds and fibroblasts start to proliferate and move toward that clot. That provisional scaffold is the key foundation for the next stage then. Proliferation. Absolutely. Phase 2. Cellular and matrix proliferation. This usually starts around 3 to 5 days after the injury. Fibroblasts actively migrate into that fibrin clot, coming from both the injured tissue edges and the surrounding connective tissue. They ramp up the synthesis of collagen and glycosaminoglycans, or GAGs. However, this early matrix is highly disorganized, and it's characterized by a high proportion of type 3 collagen.
Type 3, that's the temporary, weaker scaffolding collagen, right? Not the good stuff yet.
Correct. It's the quick and dirty construction material. Over time, it gets replaced by the much stronger type I collagen, and the mechanical strength gradually improves. This leads us into the long game, remodeling.
Phase 3, remodeling. This is where the tissue really matures, and it takes a long time, doesn't it? A minimum of 1 year, often longer.
Oh yeah, easily. Remodeling is defined by a decrease in cellularity and vascularity, which indicates the process is kind of stabilizing. Collagen density increases dramatically, and the collagen fibrils slowly reorganize themselves, aligning along the longitudinal axis of the ligament in response to the mechanical load. You also get increased collagen cross-linking, which provides the boost in tensile strength.
Okay.
A fascinating aspect here, described by Feriniers and others, is the role of specialized cells called myofibroblasts.
Myofibroblasts. So they're essentially scar cells that develop contractile properties, almost like smooth muscle.
That's a perfect way to put it. They contain alpha-smooth muscle actin, which is a contractile protein, and they're thought to be responsible for actually tensioning the developing scar tissue, kind of pulling the torn ends together and tightening the new matrix in response to strain.
Okay, so if the MCL follows this sort of textbook healing process, why is the resulting scar still considered imperfect? Why not as good as new?
Because it is fundamentally scar tissue, not native ligament. Although the overall structural strength, the ability of the entire unit to resist failure, recovers significantly, maybe 40% to 90% in animal models, the material properties of that new tissue only restore to a pretty dismal 30% to 70% of normal.
Wow, that's a huge material deficit. What defines the inferiority of that scar tissue at the molecular level?
It's all in a molecular organization, or really the lack thereof. You can see the comparison in Table 36.1. The scar tissue is weaker, it exhibits significantly more creep under constant load, and its collagen is just disorganized. Crucially, it retains an abnormal collagen profile, more type 3, type V, type 6 collagen. And it has this highly disorganized distribution of small fibrils, with far fewer mature crosslinks compared to the native pristine type I-rich matrix.
So we, as surgeons, are often managing a controlled biological failure. We're settling for a mechanically inferior scar that's just prone to yielding rather than achieving true regeneration.
That's a very accurate way to look at it, unfortunately.
All right, now we pivot to the ACL. Why can't the ACL, which obviously bleeds and gets inflamed just like the MCL, use that same healing playbook? What goes wrong inside the joint?
The ACL faces two really insurmountable biological obstacles. One is anatomical, one is chemical. The first one is pretty obvious if you've seen it arthroscopically. Most mid-substance ACL tears result in immediate significant retraction. The torn ends just involute, they curl up, and they're rarely in contact. There's no physical scaffold available for those myofibroblasts to bridge across.
Okay, so physical separation is barrier number 1. What's barrier number 2?
Barrier number 2 is the chemical killer, the synovial fluid itself.
The joint fluid, how?
The synovial fluid turns the joint capsule into a hostile, corrosive bath for healing. Immediately following the injury, that initial fibrin clot, the absolute prerequisite for starting phase E healing, is rapidly dissolved before it can stabilize. The synoviocytes, those cells lining the joint, they upregulate the production of an enzyme called urokinase plasminogen activator, or UPA.
UPA, which accelerates the breakdown cascade.
Precisely. This UPA acts as a catalyst. It converts plasminogen, which is abundant in the synovial fluid, into its active form, plasmin. And plasmin is the fibrin killer. It aggressively degrades that initial fibrin clot, totally disrupting the provisional scaffold. Murray and colleagues really demonstrated that this lack of a stable scaffold is the major biological disadvantage to any intra-articular soft tissue healing.
So the joint environment, which is supposed to protect the cartilage by lubricating it and nourishing it, is actively autodigesting the initial repair scaffold needed for the ACL. That seems like an astonishing evolutionary flaw. Or maybe it's an adaptation to quickly clear debris.
It's certainly a catastrophic reality for ACL healing. Without that stable fibrin bridge, there's just no substrate for fibroblast migration, no capillary ingrowth, no organization. Healing gets aborted almost immediately. And this biological fact dictates our entire treatment plan. The ACL simply cannot be trusted to heal itself.
This also brings up the complexity of multi-ligament injuries. If we have both an ACL and an MCL tear, how do those two biological systems interact? Does the ACL tear doom the MCL healing?
Well, the prognosis for combined injuries is typically worse, just because the overall joint stability is decimated. However, animal models show an interesting nuance. If you reconstruct the ACL, but manage the MCL non-operatively, you can still get successful MCL healing.
Oh, really?
Yeah. The restored mechanical stability provided by the ACL graft gives the MCL scar the protected, low-strain environment it needs to successfully complete its remodeling phase without excessive creep or elongation. The ACL reconstruction in that scenario acts almost like an internal splint that the MCL requires to heal properly.
Okay, so since direct ACL repair is usually off the table, we move to reconstruction. We're effectively swapping a structurally excellent tendon for a failed ligament. This biological transformation process, ligamentization, is one of the most remarkable and sometimes frustrating processes we manage postoperatively.
Ligamentization, yeah. It's a term popularized by Amiel and colleagues, and you can see the concept in Figure 36.7. It's the required metamorphosis. We are taking tissue optimized for parallel loading, like a tendon, and forcing it to transform into tissue optimized for complex, multidirectional loading, like a ligament. It is a slow, multi-stage process that fundamentally determines the graft's long-term fate.
Can you walk us through the four main phases of that biological journey? What happens immediately after we implant the graft?
The first phase is pretty grim, actually. It's a vascular necrosis. This lasts approximately 3 weeks. The intrinsic cells within the transplanted tendon, they just die off due to the lack of blood supply. The graft is temporarily just a non-living mechanical scaffold. We are essentially relying on its initial mechanical properties alone during this critical early window.
Okay, so it's dead tissue initially, then the biological revitalization begins.
Yes, starting with cellular repopulation. New cells migrate into the graft, primarily derived from the surrounding joint environment, the synovium, the fat pad, maybe the remaining ACL stump. Nutrition, initially, is sustained solely through synovial diffusion, meaning the graft is just soaking up its sustenance like a wick from the joint fluid.
Right. When does the blood supply actually return to the graft itself?
Revascularization typically begins around 6 to 8 weeks post-op. New blood vessels start growing from the graft's periphery inwards, derived from the synovial lining and the surrounding soft tissue. This is a crucial milestone as it allows the graft to transition from being just a passive scaffold to being metabolically active tissue.
And the final, longest phase. Matrix synthesis and remodeling. This takes ages, right?
It does. This begins shortly after revascularization and continues for a minimum of 1 year, often 2 years or more, before significant maturity is reached. The collagen and GAG content gradually approach that of a normal ligament. Crucially, in response to tension, the collagen fibers begin to organize, and that characteristic crimp pattern, which provides that initial toe region laxity, slowly returns.
But the persistent biological reality, as I understand it, is that even after 2 years of remodeling, the reconstructed ACL graft is never truly the native tissue we lost. It's always going to be different.
That is the fundamental trade-off, yes. Despite this extensive remodeling, the graft typically retains an abnormal unimodal distribution of collagen fibrils. Remember how the native ACL had that bimodal distribution, the large and small cables?
Right, the two sizes.
The remodeled graft primarily contains smaller diameter fibrils. This leads to a weaker overall structure, variable cross-links, and persistent elevations of type 3 collagen. This structural simplification contributes directly to the graft's persistently inferior biomechanical properties. It may stretch more or creep more than the native ACL ever would have.
And the healing at the attachment sites, the bone tunnels, that's a distinct biological problem we face, separate from the graft itself.
Absolutely. The biology of tunnel healing is paramount because this is often the common site of early failure or stretching. When we use soft tissue graft like hamstrings or tibialis anterior, healing occurs via a fibrovascular interface tissue. Essentially, it's a scar that forms between the tendon and the bone inside the tunnel. Bone gradually incorporates this scar tissue through an intramembranous process, leading to the formation of an indirect insertion site, sort of mimicking the MCL's attachment style.
Ah,
Rodeo and colleagues have beautifully documented the early development of this fibrovascular interface. In figures like 36.8 and 36.9, you can see that scar tissue bridging the gap.
so we're not rebuilding the sophisticated four-zone direct insertion of the native ACL. We are creating a strong fibrous weld inside the tunnel instead.
Precisely. That weld strength increases progressively over about 12 weeks as the interface matures. Now, if we use a bone-tendon bone graft, the bone plug itself incorporates through direct osseous healing, which generally provides a more rapid, secure fixation and retains the original histological ligament-to-bone interface. Though the debate over the ultimate mechanical superiority of BTB versus soft tissue grafts is, well, ongoing.
Okay, given this really delicate transformation process, ligamentization, which can be compromised by too much strain or slow bone tunnel integration, how do we use rehabilitation to optimize the mechanobiology without overloading the system? It seems like a tightrope walk.
It absolutely is a tightrope walk. We know early joint motion is generally beneficial. It improves nutrition for the cartilage and prevents the formation of detrimental scar tissue that causes stiffness. But the load applied must respect the graft's fragility, especially early on.
This brings up the whole closed versus open kinetic chain exercise controversy. What's the current thinking?
Closed kinetic chain exercises, where the foot is fixed on the ground, are the unquestioned mainstay of early rehab. They tend to generate co-contraction of the hamstrings and quads, which helps stabilize the knee and shield the ACL graft from excessive anterior shear forces.
Okay, so closed chain is generally safer. What about open chain?
Open kinetic chain exercises, where the foot is moving freely in space, are considered riskier, particularly early on. Lutz and others showed that these exercises, especially things like high-resistance knee extension movements, can increase anterior procassular laxity. It's likely by directly stressing the healing graft and its vulnerable tunnel interface.
So the surgeon sets the stage biologically, but the physical therapist manages the risk of structural failure through very controlled progressive loading.
Exactly. And the timing is everything. Packer and colleagues demonstrated in biomechanical models that immediate high-strain loading of the graft can critically compromise that early tendon-to-bone interface healing in the tunnels. You could literally pull the graft out of the tunnel or cause microscopic damage before biological incorporation has a chance to secure it.
All right, let's shift gears slightly and discuss the great hope and maybe the great confusion of biological augmentation, starting with PRP, platelet-rich plasma.
PRP. The rationale is certainly sound. Concentrate the patient's own platelets to create a delivery system packed with growth factors like PDGF, TGF-beta, IGF to accelerate healing, boost cellular repopulation, and enhance matrix synthesis. And to be fair, preclinical models do consistently show positive effects on graft maturation and tunnel integration, including increased type I collagen synthesis.
Okay, sounds promising in the lab, but the clinical data is still kind of a mess, isn't it?
It remains incredibly inconsistent, and the main reason is the colossal variability in preparation and application. We just don't have standardization. Every PRP product is different. Some are leukocyte-rich, some are leukocyte-poor. The centrifugation methods vary wildly, leading to completely unpredictable growth factor concentrations.
So it's impossible to compare studies.
Exactly. This lack of standardization makes robust clinical studies incredibly difficult. Andriol and colleagues did a systematic review and confirmed that while PRP might help subjectively reduce pain at the donor site of a patellar tendon graft, there is absolutely no clear consensus on improved long-term clinical outcome scores or enhanced tunnel healing radiographically. We are still kind of throwing biological spaghetti at the wall to see what sticks with PRP.
How about the more targeted approach using stem cells? Is that showing more promise?
This is definitely the leading edge, moving beyond just a soup of growth factors. Instead, we're looking at specific cell populations. Mashun and his group provided a really exciting glimpse of the future by using ACL-derived CD34+ cell sheets in animal models. CD34 plus cells are progenitor cells, right? They have a high potential for differentiation.
Okay.
By wrapping the tendon graft in these cell sheets, they specifically enhanced healing right at the critical bone-tendon interface in the tunnels, the very area that is most prone to failure and elongation.
So the goal there is to stop relying on a generalized inflammatory soup and instead try to engineer the exact biological interface required for strong fixation.
Precisely. The ultimate goal, as envisioned by researchers like Martha Murray and Braden Fleming, is maybe even bioenhanced repair using sophisticated scaffolds, not just replacement. Spalazzi and colleagues developed a highly technical triphasic scaffold. It's designed to mimic the native stratified insertion site zone by zone. Phase A for ligament tissue, Phase B for the transitional fibrocartilage, and Phase C for the bone tunnel integration. We are literally trying to build the perfect four-zone anchor from scratch. That's a significant departure from just drilling tunnels and securing a graft with screws.
So the ACL needs serious engineering, while the MCL mostly needs protection. We've covered the ropes pretty thoroughly. Let's move on to the knee's crucial gasket, the menisci.
Right. If the ligaments are primarily about stability, the menisci are fundamentally about load distribution and preserving the articular cartilage surface. They are these C-shaped wedges of fibrocartilage, basically extensions of the tibial plateau, and they're designed to dramatically increase the congruence, the fit, between the rounded femoral condyles and the relatively flat tibia.
Their structural engineering seems perfectly adapted to handle compressive force. How do the collagen fibers actually manage that load without getting crushed?
The microanatomy is just brilliant. The vast majority of the type I collagen fibers are oriented circumferentially. Think of them like a massive bundle of tight rubber bands wrapped around the tissue.
Okay, like hoops.
Exactly like hoops. When the knee is loaded axially, the fiber presses down, pushing the meniscus outwards peripherally. This compressive force is immediately converted into tension, what we call hoop stress, in those circumferential fibers.
Ah, so the load gets distributed across the entire peripheral ring, preventing the central compression from hammering the underlying cartilage.
That is their primary critical function. The circumferential fibers bear the tension. Now, to prevent the tissue from splitting longitudinally under that immense tension, the meniscus also incorporates smaller, radially oriented fibers. These act like structural ties, holding the circumferential bundles together. You can visualize this in figure 36.13. Tissac and Ahmed confirmed the specialization. The meniscus is vastly stronger and stiffer in that circumferential direction.
And the actual amount of load they bear on a daily basis is, well, frighteningly high.
It is non-negotiable for joint health. The meniscus transmits roughly 50% of the joint load in the medial compartment and a staggering 70% in the lateral compartment. And when the knee is flexed to 90 degrees, that load transmission can spike up to 85% of the total compressive force passing through the joint.
85%.
Yeah. I always tell my residents, the meniscus is the knee's most crucial gasket. If it blows, the entire system immediately starts grinding itself to dust.
And the consequences of losing that gasket of meniscectomy are well established historically, aren't they?
Oh, they are devastating. And the historical context is really important here. Fairbank first described those characteristic radiographic changes, the flattening of the femoral condyle, the spur formation after meniscectomy, long before we truly understood the biomechanical cause. Biomechanically, removing the entire meniscus reduces the knee's contact area by approximately 50%. This drastically increases both the mean and the peak stresses on the underlying articular cartilage.
And even just partial removal incurs a massive biological debt down the line.
A huge debt. Research by Seedholm showed that resection of as little as 15% to 34% of the meniscus can increase the contact pressure on the cartilage by over 350%.
350% from a small trim.
Think about that. A small trim leads to a massive, immediate jump in pressure that the cartilage just isn't designed to handle long-term. Roos and colleagues really drove this point home in their long-term study. They found a 14-fold increased relative risk of developing symptomatic osteoarthritis 21 years after a meniscectomy. This data is why the entire focus of orthopedics has fundamentally shifted from routine meniscectomy to aggressive repair and preservation whenever biologically feasible.
Beyond load distribution, the meniscus also plays a critical role in joint stability, doesn't it? Especially in the setting of an already injured knee.
Yes, absolutely. In an otherwise intact knee, removing the meniscus might not cause gross static instability. But in the ACL-deficient knee, the medial meniscus becomes a crucial secondary stabilizer, particularly against anterior tibial translation. Its removal in that setting can increase anterior tibial translation by up to 58% when the knee is flexed to 90 degrees.
Wow.
This explains why an unstable ACL injury combined with a significant medial meniscal tear carries such a poor prognosis if the meniscus isn't repaired. And it's why we are so aggressive about repairing the medial meniscus whenever possible during an ACL reconstruction.
Yeah.
It protects the ACL graft.
Okay, so if preservation is the goal, we absolutely must respect the biological constraints on healing. King's famous 1936 experiment still seems like the foundation of all meniscal repair techniques, establishing that absolute reliance on a peripheral blood supply.
King established the fundamental truth, absolutely. Meniscal lesions must communicate with the peripheral blood supply to have any intrinsic healing potential. The blood supply itself originates from the medial and lateral genicular arteries, which form this perimeniscal capillary plexus around the edge. However, and this is the key limitation, this vascularity is severely limited in its penetration.
How limited are we talking?
Vascular penetration typically only reaches the peripheral 10% to 30% of the medial meniscus width and maybe 10% to 25% laterally. This biological constraint directly dictates the classic zonal classification system, which we have to reference for every repair decision. You see it illustrated in figure 36.17.
The red, 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 white, and white, white zones. Can you quickly define those?
Sure. Red tears occur entirely within that peripheral, functionally vascularized zone. These have the highest intrinsic healing potential. Red-white tears cross the threshold. They have some peripheral blood supply, but their central margin is in the avascular zone. These often require some biological assistance to heal reliably. And white tears are located completely within the central avascular zone. Theoretically, these cannot heal normally without significant biological intervention.
Okay. And in those vascularized zones, the red, red, or the red part of a red-white tear, the healing process resembles that extra-articular ligament healing we discussed earlier. It goes through the 3 phases.
Exactly. A fibrin clot forms from the peripheral bleeding, followed by the proliferation of fibrovascular granulation tissue migrating in from that peripheral blood supply. This eventually matures into a fibrous scar. You can see this process in figure 36.19. It's a structured process, but just like with the MCL, the final tissue is a scar. Its ultimate tensile strength, unfortunately, does not reach that of normal native meniscus tissue.
Right. So, given that we know the white zone is essentially a biological wasteland in terms of healing potential, we've developed numerous techniques over the years aimed at physically introducing blood and healing factors into that avascular central region, trying to bridge the gap.
The central idea of all augmentation techniques is creating that biological bridge, yes. The simplest technique, though maybe the most conceptually elegant, is the exogenous fibrin clot.
Ah, yes, the technique that turns the patient's own autologous blood into something resembling wet chewing gum inside the joint.
That's a pretty good visual. We take the patient's whole blood, maybe centrifuge it, allow a fibrin clot to precipitate out like in figure 36.23, and then we strategically place that scaffold right into the tear site. This clot is a dense matrix, rich in platelets and growth factors, and it provides that necessary initial structure, the phasi scaffold, that the synovial fluid would typically just dissolve away.
And does it work?
Clinical data generally supports its use, particularly showing improved healing rates in challenging red-white tears and also in complex radial tears, which are notoriously difficult to heal.
Okay, so clots help. Then we move to techniques designed to physically drill paths for blood to get in.
Right. The initial concept was vascular access channels, VACs, shown in figure 36.21. These were full-thickness channels created to connect the avascular tear directly to the peripheral vasculature. The downside, however, became apparent. Cutting full channels fundamentally disrupts those critical circumferential collagen fibers.
Which compromises the hoop stress mechanism, the whole point of the meniscus in the first place.
Exactly. You might achieve some biological healing, but you potentially surgically undermine the critical load-bearing mechanism of the tissue. This led to the development of a gentler, modified technique, trephination.
Trephination, like making small holes.
Precisely. Instead of cutting full channels, we use a fine needle or a specialized trephine to create multiple bleeding puncture sites through the peripheral rim into the tear site. This allows some vascular ingrowth while minimizing the damage to those large, load-bearing circumferential collagen bundles. It respects the architectural constraints of the hoop stress mechanism much better.
Okay. And we can also stimulate the synovial lining itself to help out.
Yes, through synovial abrasion, sometimes called rasping. You can see the idea in figure 36.22. By gently abrading the vascular synovial fringe that reflects over the meniscal surface near the tear, we can stimulate the development of a vascular pannus, basically a sheet of healing tissue that extends over the meniscal surfaces. This can help deliver necessary cells and factors to marginally vascularized areas, and it's often used in conjunction with trephination or maybe fibrin clot augmentation.
And finally, we absolutely have to discuss the humarthrosis effect, that critical clinical observation that really proves the importance of marrow elements in healing.
Ah, yes, this is a landmark observation in meniscal healing. Cannon and Vittori published that key paper demonstrating that meniscal healing rates improved dramatically, going from maybe 53% up to 93%, when the meniscal repair is performed at the same time as a concomitant ACL reconstruction.
Wow, that's a huge jump.
It is. And this improvement isn't thought to be due to the ACL graft itself providing stability, but rather attributed to the hemarthrosis, the flood of blood, and, crucially, marrow elements like stem cells and growth factors introduced into the joint by the notchplasty and the tunnel drilling required for the ACL reconstruction.
So the ACL surgery itself is essentially acting as a potent biological augmentation for the meniscus repair, basically pouring in growth factors and progenitor cells from the bone marrow.
That is the compelling theory, yes. And this observation led directly to the marrow-stimulating technique of performing microfracture of the intercondylar notch in ACL-intact knees undergoing meniscal repair. The idea is to intentionally replicate that powerful hemarthrosis milieu and hopefully improve meniscal repair outcomes even when an ACL surgery isn't being done. Hashtag tag degrowth factors and regeneration.
That brings us nicely to the specific chemical messengers involved. How do meniscal cells, the fibrochondrocytes, actually respond when we bathe them in concentrated growth factors, like from PRP or marrow?
Meniscal cells respond pretty predictably, actually, but often differently based on their location, whether they're from the inner or outer meniscus, and also which factor you apply. Table 36.2 summarizes some of this. We know, for instance, that TGF-beta, transforming growth factor beta, is a major promoter of proteoglycan synthesis across all meniscal regions. That's important because it improves the water binding capacity and cushioning.
Okay, TGF-beta for the matrix. What about factors for cell migration and actually building new tissue?
Factors like PDGFAB, platelet-derived growth factor, hepatocyte growth factor, HGF, and bone morphogenetic protein 2, BMP2, have been shown to stimulate cell migration and DNA synthesis, as detailed by Pargova and others. But there's a key regional difference that Spindler and colleagues found. Cells from the outer vascularized portion of the meniscus were far more responsive to PDGFAB than cells from the central avascular zone.
Ah, so even when we deliver the right factors, the intrinsic capacity of the cells to respond might still be constrained by their original location and blood supply?
That seems to be the case. It highlights the challenge.
Speaking of PDGF, what is the current, maybe more nuanced view on clinical PRP use specifically for meniscal repair? Still mixed.
It mirrors the ACL confusion, unfortunately. The clinical outcomes remain mixed. Now, preclinical studies, especially those using standardized delivery vehicles like hydrogels to keep the PRP concentrated at the tear site, did show enhanced tissue bonding and even some signs of regeneration. However, in human trials, the results are much less compelling. Pujol and colleagues, for instance, reported a significant positive difference in MRI radiographic healing status for avascular horizontal tears augmented with PRP.
Okay, so better biological appearance on the scan.
Yes, better biology on MRI. But here's the kicker. This improved biological healing status did not correlate with improved overall clinical outcome scores, like the KOS or IKDC subjective scores at 30-month follow-up.
So the scan looked better, but the patients didn't feel or function better.
Exactly. This is the perennial orthopedic challenge, isn't it? Just because it looks better on a scan doesn't mean the patient feels better or functions better long-term. We might be creating a biologically sound scar that is still mechanically insufficient to restore normal function or prevent future degeneration.
Which means the ultimate frontier then must be true volume regeneration using stem cells, where we aren't just trying to heal the tear, but actually grow back the tissue that was lost through injury or partial meniscectomy.
This is arguably the most exciting area, moving beyond simple repair towards true biological replacement or regeneration. The work by Vangsness and colleagues is really seminal here. They conducted a randomized controlled study using allogeneic mesenchymal stem cells, MSCs, injected intra-articularly following a partial meniscectomy. They weren't just augmenting a suture line, they were looking for actual regrowth of tissue.
And the results were compelling, at least in a subset of patients.
Extremely compelling. They observed a significant measurable volumetric increase in meniscal tissue, true regeneration, in about 24% of patients who received the lower dose of 50 million cells. No such increase was seen in the control group.
Wow.
This is potentially a game changer. It suggests that the knee joint environment, when treated with the correct progenitor cells, can be induced to regrow some of its crucial gasket material.
So the future is really moving toward personalized tissue engineering, developing perhaps synthetic scaffolds, like those made from PLGA, seeded with the patient's own cells or specific allogeneic cells, designed to grow an entirely new functional structure capable of handling that critical hoop stress without relying on the patient's own imperfect scar tissue response.
That is certainly the long-term goal, yes. We are slowly moving from being primarily mechanical fixers to becoming biological engineers.
Yeah.
Hashtag outro.
Well, this deep dive has provided some absolutely essential clarity on the anatomy of the fix, so to speak. To synthesize the three core biological challenges we've discussed, the ACL fails internally because the synovial fluid's plasmin cascade acts like a corrosive cleaning crew, just dissolving the necessary fibrin clot before healing can start.
Right.
The MCL, being outside the joint, succeeds by following the classic scar cascade, but the result is a mechanically inferior structure that requires protection to mature. And the meniscus demands that we respect its absolute reliance on peripheral blood supply and its critical function as a load distributor, dependent entirely on that circumferential collagen architecture and hoop stress. Mastery of the clinical approach really requires a fundamental understanding of these molecular and cellular details.
I couldn't agree more. The complexity is immense, isn't it? From the subtle mechanoreceptors that provide the knee's internal GPS to the necessity of having that bimodal collagen distribution for optimal load handling in ligaments. Our role as surgeons is this delicate balancing act. We have to manage the inflammatory response, provide a suitable biomechanical environment for healing, and maybe offer targeted biological enhancement when necessary. We have to constantly connect the fundamental science, the collagen fibril diameter, the radioplasminogen activation, to the long-term clinical outcome of preventing premature osteoarthritis. We're not just closing wounds, we are managing scar maturation over months and years.
And knowing that we often do settle for scar tissue, a material that we know is weaker, creeps more, and retains a simpler, less organized structure, that's what really drives this relentless push for biological augmentation, isn't it? We are perpetually trying to coax that initial type 3 collagen scar into behaving more like robust, organized type I ligament or fibrocartilage, because we know the mechanical inferiority of the healed tissue is often the patient's ultimate weak link down the road.
Precisely. And that leads us right back to the fundamental, unresolved question that really governs every single recovery we observe in clinic. If the knee's static stability ultimately relies on achieving the correct collagen composition and perhaps regaining some of that critical sensory feedback loop of the ACL, and its load-bearing capacity relies absolutely on meniscal hoop stress integrity, how much of a patient's ultimate long-term recovery and resilience depends purely on their individual, perhaps genetic capacity to successfully reorganize that initial weak type 3 collagen into organized, resilient type I tissue, regardless of the surgeon's technical skill or the advanced hardware we deploy.
So innate biology trumps technique sometimes.
That innate genetic variability in healing response. It remains the ultimate unpredictable factor in every single case we treat.
That is the perfect, maybe slightly sobering thought to carry forward as we close this deep dive. The patient's own genome often determines the final structural integrity, perhaps far beyond our current control. Thank you so much for walking us through the intricate biology of failure and the evolving science of the fix.
My pleasure entirely. This foundational knowledge is really what separates a technician from a true surgical scientist, in my view.